Okay, we can go live now.
So welcome everybody to this session of short papers. It's Bas Trompetus and Graham Poston. We're moderating the table. So the first paper today is presented by Christopher Payne, Introduction of an Acute Ambulatory Clinic for Unscheduled General Surgery in NHS Tayside. Just remind us 3 minutes for the presentation and 2 minutes for questions. Thank you.
Thank you. Good evening, Mr. Chair, people, ladies and gentlemen. Welcome from sunny St Andrews. I'm going to talk about some work that we've done in NHS Tayside. This is an aerial view of Ninewells Hospital, which is the main hospital within Tayside, with the arrow pointing to the acute surgical receiving unit. Slide, please. In 2017, we had a very large number of enforced service redesigns due to various different drivers, and ultimately a number of factors at play resulted in all of the acute general surgery moving to a single centre, as well as a number of networks being put in place, including interventional radiology, vascular, urology and plastic surgery. And it resulted in the surgical receiving unit in Ninewells going from a sleepy 12 to 15 patients per day, going up to about 30 to 40 patients per day, with no change in the surgical footprint. We were able to move some staff across to help with these changes, but without any change in the inpatient footprint. Historically, we had quite high admission rates, so we set about introducing a number of service improvements to try and address the massive changes in footprint that we were facing, and we divided it into the reception phase, the acute phase, and then the inpatient phase. And one of the biggest things we wanted to do in the reception phase was to try and manage a proportion of our patients out with the traditional admit, assess, discharge pathway. And we piloted an ambulatory pathway at the end of 2018, and then we have audited the results from January to December 2019. Slide, please. The summary of the work that we did were that there were approximately 6,000 patients attended or were referred for general surgery through the acute receiving unit. And about 1 in 5 of these patients we attempted to manage through the clinic rather than traditional assessment through the bay, where about 80% of patients were automatically admitted. So of the 20% of patients that were managed through the clinic, we were pleased to note that only 10% required immediate admission from the clinic attendants, and about 70% of patients were able to be managed entirely in an ambulatory fashion. About half of them were discharged, and as you can see, about 15% required further review. 10% were put onto a waiting list, whether that be imaging, endoscopy or theatre waiting list. We had a relatively small DNA rate, as we saw most of these patients the day after their referral, and unfortunately we had incomplete data in about 10%. Slide, please. So the conclusions of this work were that we were able to manage these patients from a logistic. It's not just the medical staffing that's the difficulty when you're trying to change the way you approach these patients. It's the logistics, it's the A&C staff, it's the nursing staff, and it's a change in mindset of the patients also. And we were able to prove that we could manage about 1/5 of these patients in the outpatient settings, and from a safety point of view with relatively low admission rates. We had been hoping to use 2020 as a springboard with this ambulatory mindset in place to pilot some ambulatory theatre slots, some ambulatory CT pathways, and perhaps introduce some nurse-led processes, and that's still the plan, but obviously COVID has got in the way of that to a certain extent. Okay, any questions? Thank you.
Thanks, Chris. That was very good. I mean, I've got a few questions about this, and the first one really is, what was, if you recorded the grade of the surgeon who was seeing these patients in the clinic, and did it make any difference about seniority and experience?
So I haven't drilled down into that kind of detail. What I would say is there was, across the year, there was a general drift from a relatively high proportion of consultant reviews in the first 6 months.
Right.
When I was pestering people to do it, towards a predominantly registrar or a higher proportion of registrar-led reviews. The other drift was the ratio of new patients to return patients.
Yes.
And the process we put in place was that the criteria that these patients could be seen were they were either direct referrals from the GP, or if a registrar had seen a patient in the bay overnight but didn't think they needed to be reviewed but did think they needed a consultant review, they could be discharged to come back for that. But we found, as it became more accepted practice, that some expedited discharge patients would sneak in there and they would be coded as return patients. So there was a drift over the year, and I was hoping to see what this year would bring. But a proportion of the patients that I think were managed through the ambulatory pathway are now not seeking medical attention at the moment anyway.
Yeah. And secondly, and briefly, weekends, what would you do at weekends?
So this was a Monday to Friday service, and patients that were referred to the nurse practitioners took the calls 8 till 8, and the registrars take the calls overnight. So that the AMPs and the registrars were welcome to book patients onto the Monday morning clinics from the weekend, but we didn't run the clinic at the weekend.
Baz, do you have any questions?
Yeah, well done for starting this. It is difficult. I mean, I've been running an acute surgery clinic in Southampton since 2013, and we have ultrasound scan slots, CT slots, but it is consultant delivered. My question to you is, what did you find as the biggest challenge on doing this?
I think we have quite a traditional paternalistic approach in our department where, you know, if a patient comes with a problem, they get admitted, they get investigated until we find out what the problem is, and then they get discharged. So it's really, and the patients and the GPs that are referring the patients all have a similar mindset. So it's, I think, just trying to change people's approach. And of course, you can't change everyone's approach, because at the end of the day, it's still the consultant's name at the end of the bed. But if you can put in place a process which is better than the existing process, then people will migrate towards that. Whereas if it's less efficient, then people won't. So I think that's probably my main take-home message, is that if you can put in place a good process that people see the value in, then they'll use it.
Thank you very much, Chris.
Okay, welcome.
So let's move on to the next presentation. So the next paper is introduction. The next paper is computed tomography as a first-line investigation for patients presenting with surgical pathology.
Hello, hello everyone.
Mr. Joshi.
Hello. Hi, can you hear me?
We can hear you. Go ahead.
So this is basically a thing that we did in our DGH in Stepping in Hospital. Next slide, please. What we found is that because we've got these, as you all can also know, the surgical take has been increasing significantly. So what I looked into is all the NELA laparotomies that we did over past 15 months to see if those NELA laparotomies had an A&E visit within 1 month of within the previous 1 month of their operation, or within the previous 1 week of their operation, and with the same complaints, and what were the outcome. Our essential hypothesis was that there was no difference in the outcome. So we looked at the ED attendance in the about time frame with 1 week and 1 month of the NELA laparotomy. Next slide, please. we had a total of 176 patients who underwent the laparotomy in that period. Of these, 46 patients have presented in 1 month of the previous 1 month of their laparotomy. Of these 46, 27 presented in a week preceding their laparotomy. Of the 27 seen within 1 week of their laparotomy, 6 were investigated appropriately and were brought back as a second admission for a scan the next day, and then had their laparotomy as an emergency. So the 6 were taken out of the study. Next slide, please. The 21 remaining were actually investigated more. So what we did is we looked at the parameters, the new scoring, and we put down the NELA risk assessment for all those 21 candidates when they attended A&E for the first time and when they actually had the NELA laparotomy. So we found that the morbidity, mean morbidity, increased from 41% to 61%, an increase of 45% overall, and the mean mortality, which is the most important part, increased from 2.6 to 7.3, which was also significant. Next slide, please. This essentially, what then we did is we made a 2-week trial period in June 2019 as a part of Healthier Together in Greater Manchester area, where we CT scanned all emergency department surgical patients with a set criteria of lactate greater than 2, white cells raised CRP, age greater than 45, symptoms of bowel obstruction. We looked at all those 46 patients which failed the previous time. They would have got the CT if they were attended A&E in this 2 weeks time because they fit that criteria. We looked at the NELA laparotomies conducted 1 month after this trial, and we found that none of those laparotomies were missed. Next slide, please. This was essentially what we wanted to show, that if we do a CT scan and the patient comes in, it would decrease the morbidity by 1/3 and mortality by 2/3. The most important part of mortality is that it made the low risk patients a mortality of 2.3% go into more high risk patient, a mortality greater than 5%, which warrants an HDU bed, which eventually cascades into bed shortage for elective patients and eventually the cost for the trust as well. So this was what was proposed that we should be doing it. Thank you. Do you have any questions?
Okay, thank you, Necdet. I always thought that nobody got to see a casualty officer unless they had a CT scan these days, but what were the pathologies of the 21 cases that you investigated in detail?
Most of them were essentially bowel obstructions, which led to perforation. So those would have been picked up before as well, but unfortunately, they were either sent home or they were sent to medical specialty as constipation, and they were not appropriately CT'd. And hence they eventually, when they deteriorated even further, when they eventually got a stercal perforation or something like that, then surgeons got involved, and then that led to for the treatment for them.
Right. And were there any differences in the POSSUM or NELA scores in these patients compared to the other patients?
Yes, so that's what we did. We compared the NELA scores and the POSSUM scores to them presenting at the first time and to presenting at the second time. But when I have not looked at the data of the NELA scores of these 21 specific compared to the overall average NELA that we get in our hospital as such. But when I compared the 21 patients, their NELA score had jumped up significantly,
right?
Because they were delayed.
Okay, Vas.
Yep. So, I mean, thinking about what you presented, it's very interesting, but it sounds to me like an ED problem in your hospital, because from what I understand, the pathology was missed in ED. And I think radiology departments will be quite resistant to give free rein to ED to order as many scans as they like. So was there an issue, is there a communication problem between ED and surgery? So why they were sending patients home without surgical review?
that is what we are trying to get into. We get to the bottom of it. It's mainly they have been this is what we've seen, that there were many patients who were sent home or even sent to medical specialties for that matter, to or gastroenterology, or instead of being referred to surgeons. Of course, there are other ways around it. I'm sure you know that there are as in medical problem, patients land up on a surgical take with pneumonia because they complain of right upper quadrant pain. But so it was essentially both ways. But these patients, where if we had, that's what we were wanting to do, see that if there was some more better triage or better way of identifying which patient goes to which specialty at an early stage, that would improve outcomes.
So you
Actually,
now have
one question from Mudassar Ghazanfar here, and answer yes or no very briefly. All 21 patients were seen by the surgeons?
Yes.
Yes, that's fine, thanks. Marcin?
That's it. Thank you very much.
Thank you.
Right, let's move on. The next paper is validation of the clinical frailty score in another emergency surgical population, presented by Subramanian Palaniappan.
Hi, can you hear me?
Very well,
Hello?
thank you.
Can you hear me? Yeah.
I can hear you, yeah?
Yes, good. Okay. Hi there. My name is Subra. I'm a CT1 in ENT in Aberdeen Royal Infirmary. And today I'm presenting some work that I did doing my academic F2 placement with the Older Persons Surgical Outcomes Collaboration, OPSOC. The paper is entitled Validation of the Clinical Frailty Score in Another Emergency Surgical Population. Next slide, please. So NELA and PPOSM are two validated scoring tools that are in use to help us predict the mortality risk of patients undergoing surgical operations. So the ELF study, which is the Emergency Laparotomy and Frailty Study conducted by OPSOC, validated the use of clinical frailty score as a preoperative scoring tool to help guide decision-making processes. So the study that was conducted in Scotland recently was called Emergency Laparotomy and Laparoscopic Scottish Audit, or ELSA, which assessed the outcome of emergency surgical patients across Scottish hospitals with frailty measured using a 7-point clinical frailty score scale. So the three questions we're trying to ask is, can CFS be used to predict 30-day mortality and also length of stay in hospital? And can we use CFS to predict readmission rates to hospital? And how does clinical frailty score stack up when we compare it with the NELA and PPOSM? Next slide, please. So if we look at the different results here, the first on the top left is the mortality rate. So we're looking at the number of patients that died within 30 days of surgery. So we look at the lower end of the scale at CFS of 1, the mortality rate is 2.1%. And we go further up, it goes up to 25.3%. And we go across to sort of length of stay in hospital. You can see at the lower end of the clinical frailty score, patients are staying for a shorter period of time, on average a median of 10 days, and towards the top end of the spectrum, about 20 days. And both of those results are statistically significant. And if you look at readmission rates, we weren't able to establish a relationship between clinical frailty score and hospital readmission. And if you come across to the comparison, so how does NELA and PPOSM stack up against clinical frailty score? And we did a receiver operating curve characteristic. So, so we can see that for NELA, a score, the ROC curve is 0.84, and for PPOSM is 0.81, and CFS is 0.71. So for this receiver operator curve, a score of 1 means it's the best predictor, a score of 0 means it's a poor discriminator, and 0.5 means it's 50-50. So we can see that for PPOSM and NELA, they're above 0.8, which is good, and for CFS, it's 0.7, which is fair. Next slide, please. So we look at the strengths and weaknesses of CFS. So CFS is relatively simple and easy to use and can be used in the preoperative phase by hospital clinicians. And it's strongly predictive. However, some of the difficulties we faced were that because there are insufficient numbers between CFS scores 6 and 7 separately, we had to combine them together, so it's CFS 6 and 7. And although there was 2,246 patients in total, portions of the data were missing. Some CFS scores weren't always provided, so those had to be excluded. And although the ethnicity of the patients is not stated, it's likely that it's largely a Caucasian population, given we're in Scotland. So the conclusions that we can draw are that a greater CFS score is associated with increased mortality and longer length of stay, but not readmission risk. And although NELA and PPOSM are better discriminators for mortality, the difficulty we face is that you need to input preoperative and intraoperative variables into calculators to be able to calculate this. So when we look at CFS is relatively reliable and simple and quick, and it can be used for decision-making in emergencies to help inform decision-making going forward. Thank you.
Okay, thank you, Subra. Very nice piece of work. Have you looked at social deprivation amongst this patient group and whether that made a difference in the areas that patients are coming from?
So from what I remember of the information of the data table that was given to us by the Scottish government, I don't think the index of multiple deprivation was recorded in that.
Right.
But I think that's a very valid point that you make, because also Scotland, if you look at places like Glasgow or Dundee, there's a lot of deprivation in these kind of areas. Yes. Whereas if you go to somewhere like Edinburgh or the borders, there's very much less so. And we know that the patients, the area where patients live influence their health. And I think that's a very valid point that you make, and something that probably needs to be looked into.
Yeah, I mean, I do a lot of medical legal work, and when I'm investigating somebody who's died after a complication, in the law in England and Scotland is on the balance probabilities, would they have survived or not? Now, I do that calculation by POSM and more recently using NELA. Do you think CFS should also be used in that? Can you say on the balance probabilities, by 51% or more, they were going to die anyway?
I think that's a difficult sort of question to answer. I think what CFS shows is that it gives a very sort of snapshot sort of indication in that period in time. If someone has a very high CFS score, we already know that people who are more frail, because the good thing about this study was that it covers a broad range of age groups. So even people who are in younger age groups can also be frail. So it helps give us a snapshot decision-making at that point, whether this person would be a suitable candidate for surgery, whether they would likely to survive, or whether it'd be better to try conservative management. So I think if you're talking purely on the basis of numbers specifically, I think NELA or PPOSM would be better in that aspect in case of illegal legal processes. But if you're talking about a clinician making a decision on the spot, I think CFS, because it doesn't require all these other factors, it gives a better snapshot indication for clinician at that period in time.
Okay, thanks. Vas, back to you.
Thank you very much for your presentation. So we're going to move on.
Thank you.
The next presentation is knife to the skin timing in emergency laparotomy. Are we quick enough? Presentation by Varun Putnam.
Hello, good evening, everyone. Can you hear me?
We can, yes.
Yeah, hi. My name is Varun, one of the surgical registrars at Western Hospital. So, next slide, please. So definitive source control is pivotal in achieving ideal outcomes and patients assessed to undergo emergency laparotomy, especially in certain cases of bowel ischemia and bowel perforation with generalized peritonitis. The NELA data suggests that 84% of these patients requiring immediate surgery arrived in theater in the required time frame, but it does not specifically mention knife to skin timings, which are necessary for absolute source control. So we try to assess the time difference from arrival at theater and knife to skin and its impact on patients' mortality and morbidity. Next slide, please. So we looked at 100 locked patients from 2019. These patients were locked in the sense that the data was not added to or edited in any other way. And we tried to calculate the median time intervals from the decision that's made to surgery to theater, that is to the anesthetic suit, and from anesthetic suit to knife to skin, along with the other patient risk factors were evaluated. Next slide, please. So the median age of these individuals was 71, which relates to NELA, which is at 64. The majority of these patients had ASA score 3 and median frailty index of 4. The median time interval from decision to surgery to arrival to theater was 6.12 hours. And from theater arrival to knife to skin was 2.3 hours. The median surgery period was 2.18 hours, and a notable number of these patients, about 54 of them, had HTU-ITU admissions. After this abstract, we also looked at the number of deaths in this cohort of patients of 100, which were about 14. And we looked into the NELA and the POSSUM scores of these patients. The median NELA score was around 44%, and the POSSUM score was around 47%. The mean ITU and HTU admission duration was about 8, and they all had ASA score of 3. Next slide, please. So in conclusion, preemptive resistive measures and early indication for CT scan when there is a strong suspicion of surgical pathology can help in these cohort of patients to make a timely decision for them to be taken to theater. Although antibiotic timings have significantly improved, but the definitive source control is lacking due to logistic factors and infrastructural constraints. Not just timely intervention, but early intervention is quintessential for ideal outcomes. Thank you. Any questions, please?
Thanks very much, Varun. A number of questions, really, but first one, obviously, is the availability of the emergency theatre. I mean, you have 24 hours every day emergency theatre available at Wiston.
Yes. We've got one theatre, but in case there are multiple cases, we can always bring in the issues with the anesthetic staff. So we always have a second anesthetic staff on standby, and the theatre staff are more than happy to open up another theatre if need be.
Right, and that's for general surgery.
That's for general surgery. Yes,
right.
Yes.
And that leads on to my second question: the availability of consultant anaesthetists. And what's the seniority of the anaesthetist input into these patients?
All patients are discussed with the senior consultant anesthetist at the time of the decision that the patient needs to have for surgery, and most of the times they are there to help with the surgery part.
Vas,
Yeah, so it's quite interesting. You mentioned median anesthetic time 2.5 hours. Is that right?
Yes, please. Yeah.
So it sounds to me excessive.
Yeah, it is.
So
we actually didn't expect it would be that long, but when the data was analyzed, it did amount to that much. All these timings were taken from the input of the theater staff into the opera system. So I presume that they're putting the timings maybe at the time of a huddle, or the patient, sometimes they do it when the patient arrives to the theater. So I think there's a little discrepancy, and which is the reason why it looks a little higher. But even when we looked into the death patients, it was about 1.3 hours. From the decision to the patient arriving to theater was 3.5 hours, so which is quite significant.
have you discussed that with your anesthetic colleagues?
Sorry?
Have you discussed that with your anesthetic colleagues?
Yes, we did.
And they are happy with those figures?
That's debatable.
Okay. Right. Okay. Well, thank you very much.
Thank you so much.
So we're going to move on to the next presentation. Hyponatremia. Is hyponatremia a marker of complicated appendicitis in children? A retrospective review. Presented by Joseph Doyle.
Hi there. Hi, can you hear me?
We can,
yes.
Hi, so my name is Joseph Doyle. I'm a core surgical trainee in Northern Ireland, and this is a presentation of my audit project looking at hyponatremia as a marker of complicated appendicitis in children. Next slide, please. So patients presenting with complicated appendicitis, defined as a presence of perforation or gangrenous appendix intraoperatively, tend to have worse outcomes and associated morbidity. hyponatremia has been shown to be a specific marker for perforation in cases of appendicitis and diverticulitis, predominantly involving adult populations. This was a retrospective audit comparing the rate of hyponatremia with pathological outcome for all pediatric appendicectomies performed at Antrim Area Hospital over a 2-year period. It also looked at secondary outcomes involving the presence of raised inflammatory markers and duration of hospital stay for the children. Next slide, please. So overall, in the 2-year period, 131 pediatric appendicectomies were performed. 6.9% of them were found to be hyponatremic, which included 43.8% of those who had a pathological outcome of complicated appendicitis, compared with 1.7% for other pathological outcomes. The mean sodium concentration on admission to hospital was also found to be significantly lower in cases of complicated appendicitis. And then also looking when we looked at hyponatremia as a marker of complicated appendicitis, compared with other pathological outcomes, it was found to have a high specificity and also a positive predictive value of 78%. This equated to a positive likelihood ratio of 25 and an observed odds ratio of 44. These results sort of suggested that the presence of a hyponatremia in those undergoing appendicectomy is predictive of complicated appendicitis and appears to validate its use as a diagnostic marker. Next slide, please. So looking at the secondary outcomes, which had as you can see from the graph, all cases of complicated appendicitis had elevated inflammatory markers more than for other pathological outcomes. And these patients tended to have a significantly longer mean duration of inpatient stay at 6.5 days compared with 2.4 for other pathological outcomes. So in conclusion, overall, this is a small cohort of pediatric appendicectomies, limiting any conclusions drawn from the data. However, the results do seem to support prior study of validating the use of hyponatremia as a marker of complicated appendicitis and specifically applying that to pediatric populations. Thus, the presence of hyponatremia along with elevated inflammatory markers in children presenting with lower abdominal pain could be or may be suggestive of complicated appendicitis and predictive of longer inpatient stay. Thank you.
Thanks very much, Joseph. Hyponatremia has been a factor in possum for the last 30 years since Graham Copeland first published that paper. Your median score of 135 millimoles per litre in the complicated patients only scores 2 on the possum scoring system. And you've really got to get below 130 in adults in possum to really get a high predictive score from hyponatremia. What do you think is the difference in the relevance of this in children to adults?
So I guess possibly the importance of identifying hyponatremia in these complicated surgical cases and the difficulties with perioperative IV fluid administration in children, you know, the importance of identifying it early if they're going to be quite complicated as well.
Bas, have you anything?
Yeah, so what would you do different if you find hyponatremia?
Well, I guess it would increase your suspicion of having a case of complicated appendicitis, which would probably influence whether or not you're going to sit on your delay on timing to operative intervention in a child. You know, if you're suspecting complicated appendicitis, rather than sitting on the patient until the following morning, it might influence your decision to operate that evening.
Okay, thank you very much.
Thank you.
So we're going to move on. The next paper is the utility of laparoscopy in blunt abdominal trauma, a systematic review, presented by Umesh Jayaraja.
Hi everyone, I am Dr. Shatan Shatamurthy, working as a registrar in surgery at National Hospital of Sri Lanka. I am presenting this on behalf of Dr. Umesh Jayaraja. Our study is about the utility of laparoscopy in blunt abdominal trauma, a systematic review. The role of laparoscopy in penetrating abdominal trauma has been shown useful. The utility of laparoscopy in blunt abdominal trauma is controversial. Laparoscopy has been initiated in the local setting for blunt abdominal trauma. There is a lack of consensus in the use of laparoscopy in blunt abdominal trauma. Therefore, the aim of our study is to evaluate the existing evidence in the utility of laparoscopy in blunt abdominal trauma. Slide, please. Databases were searched using search term trauma, blunt abdominal trauma, and laparoscopy. And the top right corner, the Prisma flow chart shows how we ultimately ended up in 19 studies that were included in our systematic review. The total number of studies were 19 and total patients analyzed were 745. And the mean age of patient was 36.4 years. The pie chart shows the gender distribution. 70% were male and 30% were female. Next slide, please. Around 90% of laparoscopy yielded positive findings. The median hospital stay was 11.2 days. Only one study mentioned about the missed injury or reoperation. Our study shows the conversion rate was 24%. 50% of the conversion were due to the complex nature of the procedure. 30% the laparoscopy was performed merely for diagnostic purpose. In 20%, hemodynamic instability was the cause for the conversion. When we see the outcome, considerable heterogeneity in reporting outcome. Most studies shows laparoscopy in blunt abdominal trauma in selected subgroup of hemodynamically stable patient was safe and useful. Missed injuries were underreported. We could not perform meta-analysis because the clinical heterogeneity of our study population. Slide, please. The bar chart on left side shows the pattern of injury detected during this laparoscopy. Small bowel injury was the commonest injury detected during the laparoscopy, followed by solid organ injury, mesenteric, and colorectal injuries. The table on right side shows the complications. The only 17% reported complication, and most of them were short-term complication. Among them, surgical site infection was the commonest, and few intermediate and long-term complications. Therefore, we concluded laparoscopy may have an important role in the selected subgroup of patients with blunt abdominal trauma. There is a lack of evidence to formulate recommendation to develop specific guidelines in terms of patient selection and type of injury that could be managed with laparoscopy. Our recommendation is to conduct a large-scale prospective study with proper patient selection criteria incorporating preoperative imaging protocol, suitable comparison groups to assess the utility of laparoscopy in blunt abdominal trauma. Thank you. Any questions?
Thank you very much, Kishantam, and congratulations. Is it midnight in Colombo?
Yeah.
It is. Staying up. Yes, I mean, within your systematic review, were there data or to show whether or not laparoscopy conferred further benefit in these patients over the CT scan, which most of these patients would probably get? So what further benefit did you find for the use of laparoscopy over a straightforward CT scan?
Yeah. In laparoscopy, we can do a systematic visual analysis from DJ flexure to these things. And the CT scan does not show some small kind of injury, in merely small injury. So we could say that CT scans might be inconclusive in some cases. So laparoscopy is better than CT scan.
Okay, Vas.
Yeah, I mean, I agree with this point. You know, particularly small bowel injuries can be missed. The CT will not pick them up. I suppose the question is then, you repeat the CT or you do a laparoscopy if the patient doesn't settle. You know, I think that's probably the main use of it. I mean, do you think that is useful for anything else? Can you hear us?
Yes. Can you hear?
Yes.
Yeah. Do you think it's useful for anything else than diagnosing a missed small bowel injury?
No, we can utilize it for the therapeutic usefulness as well. For in solid organ injuries, we can use as a therapeutic value. It has a therapeutic value. We can lacerations can be sutured in liver laceration and splenic laceration grade 1, 2, and there are specific measures we can apply through the laparoscope.
Okay, thank you very much. So we're going to move on to the next presentation. A tailored protocol in the management of penetrating neck injuries, a cohort study presented by Ahmed El-Shire.
Hello, hi, I'm Ahmed. I'm a surgical consultant in Cairo University Hospital. I'm currently working in UK, but this presentation was done when I was in Cairo University Hospital. Next slide, please. So quickly, for the background about the management protocols in neck injuries, it started with years ago about mandatory separation for all injuries in neck injury, and then passed to selective protocols in management of this penetrating neck injuries, which usually do mandatory separation to zone 2 injuries. Till 2013, there was a landmark study about no zone approach, which treats the neck like one zone, depending on the CT scan and depending on physical examination, and without doing any mandatory or previous selective approaches. And there is a lot of papers after this paper speaking about using the CT scan physical examination to determine the patient's needs an operation. However, there is still no international guidelines till now. So in this study, we looked, it's a prospective study. We looked for all of patients came with penetrating neck injuries from 2012 and 2014. All of them were resuscitated by ATLS, and the unstable patients went direct to theater, either hemodynamic or airway unstable. However, the stable patients, we classify according to the physical examination to symptomatic or asymptomatic group. Post-asymptomatic group and the patients with soft signs had a CT scan, and if it's negative, they stay for 48 hours under observation. If positive, we deal accordingly, either direct exploration, or if it's zone 1 and 3, we could sometimes use endovascular treatment. For the patients for hard signs, all of them need exploration. Zone 2, direct surgical exploration. However, zone 1 and 3, still we need to do the CT scan to check if we can do an endovascular treatment for them or not. Next slide, please. So we have 85 patients in this study, most of them in males, and mean age is 27. Most of them with stab injuries, and zone 2 was the commonest affected zone. If we look for this table quickly about this is the presentation we have. All of the patients come unstable, had injuries. All of the asymptomatic patients didn't have injuries in the CT scan, apart from one patient had a partial carotid injury, which need exploration. All of the patients with hard signs had injuries, apart from one patient had expanding hematoma as a hard sign, but didn't have injury in exploration. Soft signs, about 0.5%, about 45% had injuries on exploration. So if we look for the CT scan results, we find it's quite significant for their values, which give us in the CT scan for these patients. We have only one case that's a false positive from the CT scan, and 4 cases was false negative. And actually 3 of them on exploration we find just was a muscular bleeding from unnamed vessels. So we managed to conserve on 31 patients, which is about 37%, and we operated about 54 patients, and 3 of them managed to be done by endovascular techniques. So overall, we have 65 different injuries in 50 patients, and most of them was vascular injuries. About 14 patients only has aerodigestive, either tracheal or esophageal injuries, and 4 patients has nerve injuries. Next slide, please. So by conclusion, by applying this protocol, we have only 2 missed injuries, and these 2 missed injuries were in the intervention group. No one was, no missed injury in the conservative group, and these 2 missed injuries was a nerve injuries and has been missed during the surgical exploration, which was done for a vascular injury. We have 4 cases of negative exploration, and we avoided 31 unnecessary exploration, which is a conservative group. We have only 2 cases of clavin-induced grade 3 and 4, and we have 4 cases of mortality. 2 of them was just injury related, which is massive bleeding and was unstable when they came, and they died on admission. And the other 2, one of them was myocardial infarction, and the other one was a problem, neurosurgical problem, and died from it. So overall, the third protocol we did, which depends mainly on physical examination and CT scan with less dependence on the zone examination, was high efficiently. However, we still need more studies using a protocol like this protocol to apply in larger number of patients. So zone classification now is losing popularity, especially over last years, and the multi-detector CT scan can diminish the role of another additional investigations like Doppler's contrast swallow and bronchoscope to be used routinely in management of penetrating neck injuries. However, in our studies, some patients need to have contrast swallow and bronchoscope. If we have any suspicious injuries in the CT scan, we need to do some contrast swallow and some Doppler's and bronchoscope, but it's not to be used routine for all patients. Thank you.
Okay, Ahmed, thank you very much. A nice piece of work. You did this prospective study between 2012 2014.
Yeah.
Has your tailored protocol evolved since then? Have you taken it further?
Yeah, so this was the first results we have since we applied. So this was the first time we applied this protocol in our department, okay? And after that, we continue on this protocol. However, I don't have like a hard evidence about the results which is collected after that. So I collect this data when we applied the protocol for the first time, but I don't have the results which will applied after that.
Okay, and I noticed, I mean, you've moved to Hull, and have you noticed any difference in the etiology of penetrating neck injuries between Hull and Cairo?
Yeah, so penetrating injuries here is quite less, and it's mainly stab wounds. However, back in Cairo, we saw a lot of so it's mainly stab, still mainly stab, but we have shotgun injuries, we have bullet injuries, sometimes like motor car accident, severe motor car accident with degloved injuries in the neck. So it's quite different between here and in Cairo. Here is mainly stab, and the numbers is much less compared to there.
Yeah.
It's the other thing is, especially that Cairo University is a major trauma center in Cairo, so most of referrals go to there. That's why we have quite larger numbers than the other hospitals. Yeah.
Back to you, Vas.
So Ahmed, well done, very good work. Now, taking into account these are complex injuries and require various specialties involved, who do you think should take the leadership in managing those injuries?
So again, it's quite different because here in UK, most of the neck problems, it's managed by ENT, but back in Cairo, as a general surgery team needs to be involved with, because mainly the esophageal injury and these things is done by us as a general surgeon. So usually the patients come to the general surgery, and if we need an ENT for tracheal injuries, they be involved with us. If there is any special like carotid injuries seen in the scans, then the vascular team is involved with. And actually in this study, one of the 2 consultants are vascular consultants. So one of the prof and the other consultant, both of them are vascular consultants, which were involved in that study as well.
Thank you very much.
Thank you.
So we're going to move on. The next paper is called Routine Elderly Care Physician Review of Patients aged over 70 is associated with fewer deaths and reduced length of stay after emergency laparotomy, presented by Philip Herod.
Good evening, my name's Phil Herod. I was a registrar in Derby last year when I did this work, which looked at our institution's NELA database. Next slide, please. So, as we know, successive NELA reports have highlighted that there is a lack of input of healthcare of the elderly positions in the post-operative care of older patients having a laparotomy. Our institution made this a priority after the first NELA report, and so the rate of our patients receiving a post-operative review by a geriatric medicine consultant in our institution rose from 9% in year 1 to 76% in year 5. We aimed to assess the impact of this increase on both post-operative mortality and length of stay. To do this, we looked at our institution's NELA database for the first 5 years of NELA, and we included all patients aged over 70 at laparotomy. Our outcomes were 60-day inpatient mortality and post-operative length of stay. We investigated it using a univariate regression analysis. Next slide, please. So our cohort comprised 411 patients that are all over the age of 70, with a median age of 78. The overall unadjusted 60-day mortality of our cohort was just under 11%, and just under half of these patients had a post-operative review by a geriatric medicine consultant. And as I intimated on the last slide, this increased from 9% of the patients in year 1 to 76% of the patients in year 5. Throughout the 5 years of this study, 60-day inpatient mortality of our patients reduced from 14% in the first year to 9% in the final year. However, unfortunately, we were underpowered to show significance for this. Thankfully, though, we did find some significance for post-operative length of stay, which reduced on average by 8.5 days from year 1 to year 5, with a highly significant regression coefficient. Next slide, please. So, in conclusion, routine review by a geriatric medicine consultant of patients having a laparotomy over their 70s was associated with a decrease in mortality and a significant reduction in post-operative length of stay after an emergency laparotomy. This is just an association and it can't imply causality, and further work needs to be done looking at confounders that could be present in this analysis. And we also need to consider the economic and workforce implications of providing routine review of all patients in their 70s and 80s after a laparotomy. Further work also needs to be done looking at the potential impact this has had on discharge destinations of these older patients, and any impact this has had on their quality of life. These results, however, are very encouraging, and further investment in shared care between geriatric medicine and general surgery in older patients having a laparotomy should be strongly considered. Thank you very much.
Thanks very much for a nice presentation. Okay. I don't know what's happened there. Orthopods have been doing this for years, bless them. Why has it taken us general surgeons so long to get around to doing this?
That is a very, very good question. I don't know whether it's that we aren't quite as bad at looking after the medicine of these patients. That's the cynic in me. I think a lot of this is down to workforce implications, though, and whether there are enough geriatricians in an institution to do this.
Mm-hmm. Baz, are you?
So yeah, actually, we have employed a dedicated care of the elderly physician consultant to work with the acute surgery team to support our patients, and I think it offers great benefits. Have you tried to have pre-operative review?
So we haven't looked at that in detail in this study. From anecdotally from the time I had spent at Derby, that happened very rarely. Often, a lot of these patients having a laparotomy is fairly urgent. Input from consultant physicians out of hours is potentially quite difficult to achieve sometimes. Some patients, so if it's a laparotomy for bowel obstruction, say, where there is a bit of time, you can anticipate this 2 or 3 days in advance, and sometimes that does happen. But for people with peritonitis, there's very little time pre-operatively, let's say.
Thank you very much.
Okay, thank you. We're going to move on now to the talking posters, and the first one is management of splenic trauma. At the District General Hospital, since the introduction of trauma centres, are we treating patients appropriately by Vijay Nirbad? Vijay. Vijay, are you there? Are you on mute?
He is there, but I think he's on mute. Vijay, you're on mute.
PJ, you need to press the mute button, the bottom left of your screen.
Vijay, can you find the mute button?
I think he's left now. We can probably
Okay.
move on to the next one.
Right. Okay, we'll move on to the next one then. Next paper is compliance with Royal College of Surgeons commissioning guidelines on paediatric emergency appendectomy in a district general hospital with Adam O'Connor.
Hi, good evening. My name's Adam. I'm a general surgery CT2 in the northwest of England. This was a project that I did earlier in the year at Royal Blackburn as a CT1. And it was born out of the fact that we noticed as juniors that there was quite a large variation in the way that right iliac fossa pain was managed in all patients, but notably in paediatric patients as well. The RCS, in association with the British Association of Paediatric Surgeons, commissioned guidelines in 2014 to monitor standards in emergency paediatric appendectomy. And essentially those standards were that the negative appendectomy rate should be less than 15%, 90% of procedures should be carried out within 12 hours of a decision being made by a consultant surgeon to operate, and less than 1% of cases should be in patients previously discharged without prior diagnosis. Essentially, this was a retrospective audit of a busy district general hospital's management of paediatric patients with regards to said guidelines. And essentially, we just looked at the last 100 paediatric appendectomies at the trust. We interrogated our electronic theatre lists to identify such patients, and then performed a thorough analysis of their paper notes to record the outcomes in terms of whether the technique was performed open or laparoscopically, the subsequent histopathology report to allow us to assess the negative appendectomy rate. We also noted the intraoperative findings, the length of stay, whether the patient had presented previously and been discharged, and also whether there was any subsequent post-operative complications. Essentially what we found is that the average age of patients presenting was just under 11 years of age with an average length of stay of around 3 days. The negative appendectomy rate was around 14%, so just under the guidelines recommended figure. 89% of operations were carried out within 12 hours of a senior surgeon's decision to operate, which was slightly under the recommended guidelines. Only one patient had presented previously and had been previously discharged without a diagnosis of appendicitis being made and subsequently reattended for operation. 35% of all the patients had a complicated appendicitis at operation. 11% was our post-operative complication rate. The majority of those, 6 of which had simple wound infections. One patient had a deep wound infection that required transfer actually to a paediatric tertiary facility. Just for further interest, the median preoperative CRP was only 29. Some people thought it may have been higher, but quite a large range. And
in the interest of time, could you get your conclusions?
Sure, yeah.
Right.
So essentially, our practice is quite favourable in comparison to national commissioning guidelines. We're slightly removing too many normal appendices, and perhaps the reason for that is our lack of ultrasound use and a very busy emergency general surgery take in the adult population. Thank you very much.
Thank you. Baz, have you anything you want to ask? Baz has disappeared.
Thank you very much. How do you think you can reduce your negative appendectomy rate?
Well, I think we didn't use ultrasound in many patients. I know that the different surgeons will have very different opinions on whether ultrasound is of use in paediatric patients. but we only used that in 18 of the 100 patients, for which it was positive in 4 of them. So I think ultrasound and access to ultrasound is certainly one aspect of that. And perhaps more repeated clinical examination as opposed to going straight for diagnostic laparoscopy may reduce the negative appendicectomy rate.
Okay, thanks very much. Thank you. We'll move on now. Vijay has turned up. He's sorted his mic out. So I'd like to go back to the first paper again, Management of Splenic Trauma at District General Hospitals and Introduction of Trauma Centres. And just remind speakers to stick to 2 minutes, please. Otherwise, I'll stop you.
Can you hear me now? Hello, can you hear me?
We can.
Sorry, my connection, so I'll leave out the video.
Don't worry.
So this is essentially a retrospective single centre study looking at management of splenic trauma at a district general hospital to see whether our treatment has changed since the introduction of trauma centres in 2012, given the potential for de-skilling and effect on patient outcomes. So we looked at all new cases of traumatic splenic injury presenting to our hospital since 2011. We excluded a non-traumatic injury, iatrogenic injury, and in total 29 consecutive, median age of 40, and a male to female ratio of approximately 3:1. The table in the top right corner shows that the most common grade of injury was WSES grade 1, so this is a mild injury. And the final column on the right-hand side shows that almost all cases were treated in line with the WSES guidelines, for the exception of some grade 3 injuries, as you can see. Now, this is because, although correctly managed non-operatively, the guidelines suggest that grade 3 moderate injuries should undergo angiography and potential embolization therapy. However, it's important to know that these were discussed with the MTC at the time, and management was as per their advice. The bar chart there shows the number of cases per year going from 2011 to 2009, and it's color-coded as per grade of injury. Although we only had 6 cases before 2012, the introduction of MTCs, we can't accurately conclude whether, or accurately compare management before and after, but there is a general trend of fewer higher grade injuries presenting later years. So those are the yellow and gray bars. And we can attribute this to the diversion of major trauma to regional trauma centers as this has become established. So in conclusion, there's a relatively low incidence of splenic trauma presenting to district general hospitals, with about 3 to 4 cases per year, this to our hospital. Despite this, most of them are being treated in line with guidelines. Obviously, this has implications on clinician experience and training when it comes to managing trauma, and stresses the importance of continual professional development in trauma and keeping up to date with latest guidelines for clinicians outside of major trauma centres, as well as that familiarity and importance of establishing treatment pathways for these patients regionally, and awareness of embolization therapies, which are becoming more routine in terms of improving patient outcomes. Thanks very much.
Thank you very much. Raz, anything?
Thank you very much for your presentation. In our local trauma network, actually those injuries are managed only in the major trauma centers. So do you think it's appropriate that you continue to see major trauma?
The majority of major trauma cases will be diverted to the regional trauma center. As you can see from the results, most of these are no longer coming to our hospital. We tend to see the minor grade ones, and these tend to be picked up on scanning with a low suspicion of major injury. So we are seeing fewer of these at our hospital, but I think the key being the ones that you can get caught out for. It's important to know what the regional trauma pathway is, where the resources are, and how you can refer to whether that's the interventional radiologist or the trauma team when needed.
Okay, thank you very much. We'll move on now to the next presentation, which comes from the William Harvey Hospital in Kent, and it's Surgical Emergency Assessment Unit and Emergency Surgeon of the Week, a paradigm shift to providing emergency surgical care. And Hesham Saeed. Hesham, are you there?
Yeah, can you hear me?
Yes.
Hello, good evening. My name is Hesham Mohammed. I'm a General Surgeon Registrar. I'm going to present today our work in the Emergency Surgical Assessment Unit and the introduction of Emergency Surgeon of the Week in William Harvey Hospital in East Kent. And I'm going to talk how this kind of changed our paradigm in providing emergency surgical care. So, as an introduction, the medical emergency service in the NHS is quite outstretched, with NHS statistics showing patients waiting for more than 4 hours are increasing in A&E for the last 10 years, and the satisfaction rate are decreasing. Our surgical emergency assessment unit started in October 2014 with a dedicated general surgery team and an ambulatory unit space and staff. Emergency Surgeon of the Week followed after that in November 2017. Our aim was to provide a safe, cost-efficient, and patient-satisfactory emergency surgical service. We have done a retrospective analysis for the data collected since the start till September 2019 from our Patient Information Center and from our own logs and from the family and friends questionnaire. So since the start, Surgical Emergency Unit has attained for more than 16,000 patients, with around 68% discharged home and 32% admitted in the hospital. As you can see on the first graph on the right side, the dotted line shows the average admission per month. It was around 309. After the introduction of the Surgical Emergency Unit, it dropped to 202 per month. And that further decreased to 153 per month after implementing of the Emergency Surgeon of the Week, with a total overall reduction of around 45% of admission rate for surgical patients in the hospital. This is compared to normal and rather increasing A&E activities in some of the years. One of the main factors for this kind of reduction was our dedicated imaging service in the Surgical Emergency Unit. So we had a dedicated slot in a semi-emergency kind of place to do CT scans and ultrasounds, and we have performed more than 3,000 ultrasound scans and more than 2,000 CT scans in that place. Our average length of stay for patients in SEU was around 4 hours, readmission rate of 7%, and we introduced further hot clinic service and incision drainage capabilities under local anesthesia. Patient satisfaction was quite paramount for our service, and as you can see on the second graph on the right, our patients were recommending our service by 98% likely or extremely likely, and that was much better than compared to other areas in the hospital like surgical wards and A&E. In conclusion, we believe that a kind of paradigm shift in providing emergency surgical care is required, and that the SEU and the Emergency Surgeon of the Week can provide a solution to relieve the capacity and financial pressure and provide high quality patient care. Thank you.
Thank you, Hashim.
Thank you for your presentation. Have you looked at the length of stay?
Yeah, so our average length of stay was 4 hours, but that was including in it the time for the patients to have their scans as well in our unit.
So I meant those who actually were admitted. Have you looked whether there was a reduction in the length of stay as a result of your initial management?
No, we haven't checked the length of stay for admission patients now.
Okay. Thank you very much.
Okay, thank you. Moving on, the next presentation is CT versus intraoperative findings for patients undergoing emergency laparotomy. Does time of day matter? And it's Sophie Davidson. Sophie, you there?
Hello, yes, so I'm Sophie. I'm a surgical registrar in Northern Ireland, just did this project in Antrim last year. So we're looking at CT versus intraoperative findings for patients undergoing emergency laparotomy. So emergency laparotomy has primarily been used to identify and treat the cause of severe abdominal pain. However, with improved access to CT and enhanced image quality, the majority of patients now have preoperative CT, and according to NELA, cross-sectional imaging should be considered as a minimum standard within an emergency laparotomy pathway. But with increased demand for CT, we're increasingly outsourcing our radiology reporting within the NHS, and this was certainly the case within our own trust. And anecdotally, we had 2 cases of out of our CT reports not quite matching up to the intraoperative findings. So we decided to audit the process and assess, was there any discrepancy between CT reports and operative findings, and was there any differences between in-hours and out-of-hours CTs. This was a retrospective study looking at patients who underwent an emergency laparotomy between November 2018 and November 2019. We used our theatre management system to identify these patients and our electronic care record to collect the data. The intraoperative findings were then compared with the CT report and categorised as fully accurate, partially accurate or inaccurate, and we excluded any patients who did not have a preoperative CT or where the intraoperative diagnosis was unclear. We had a total of 121 patients who had an emergency laparotomy, and 95.9% of these patients had a preoperative CT. Around 51% were reported in hours and 48% out of hours. 2 patients who had an out of hours CT were excluded as they did not have adequate intraoperative information recorded. Overall, 78.9% of the CT reports were found to accurately correlate with the intraoperative diagnosis, and there was no difference between our in hours and out of hours CTs. 15.8% were felt to be partially accurate, with an even 50-50 split between in hours and out of hours CTs. However, none of these patients underwent an unnecessary or negative laparotomy as a result of this. 5.3% of the CT reports were felt to be inaccurate, with 33% of those being in hours and 66% being out of hours. However, this was not found to be statistically significant, and our overall figure is in keeping with the NELA figure for inaccurate CT reporting. Of note, one inaccurate in-hour CT, which is arguably the one patient who probably underwent an unnecessary laparotomy, had commented on an incarcerated umbilical hernia, but they actually had metastatic disease with the mental deposits. So while numerically speaking, our out-of-hour CTs accounted for more inaccurate scans, probably the most serious for the patient outcomes was the inaccurate in-hour CT. But to conclude, our preoperative CT is performed for the majority of patients undergoing emergency laparotomies, and the CT findings in this cohort of patients correlated accurately with the intraoperative findings in most patients. There was no statistically significant difference between our in-hours and out-of-hours reporting in this cohort, and therefore time of presentation we felt should not delay patient imaging in those presenting with an acute abdomen. Thank you.
Thanks, Sophie.
Thank you very much for your presentation. So what you say is that you are happy having an out-of-hours reporting by a third-party company?
As this stands, anecdotally, we felt that there possibly was more of a discrepancy, but whenever we actually looked into these patients, there wasn't actually as much difference as we thought. So in general, as we said, most patients did not undergo a negative or unnecessary laparotomy when we looked at the 121 patients. So even if it was an out-of-hours report that we felt maybe didn't accurately reflect, it still gave us more of an indication of where the pathology was, rather than going in blind and not knowing what the problem was. So it at least gave us some clue as to where the pathology was, rather than having nothing at all. So we felt that it did help, and there wasn't a major discrepancy between the two.
Okay, well, thank you very much. Penultimate presentation tonight is the impact of a second duty registrar in the surgical assessment unit of a district general hospital with Mohammed Ali. Mohammed, are you there?
Yes, I'm here. Can you hear me?
Can, yes.
Hi, good evening. I'm here to present our closed loop surgical audit study, which is the impact of the second duty registrar in the surgical assessment unit in our district general hospital. As we know, the surgical assessment unit is well-recognized model for the management of non-acute surgical patients, and it also provides a faster route in recognizing acute cases by the on-call team and providing early diagnosis and access to theater if required. However, with the increasing number of referrals to the surgical assessment unit, the patient waiting times have been on the rise. And that subsequently delays the treatment plans and management of the acute surgical cases. We think that the surgical assessment unit needs to adapt to with these rising demands to cope with the challenges and strengthen the surgical team. For that, because our surgical assessment unit, which is a fairly busy district general hospital, our surgical assessment unit sees an average of 206 patients per week. And that's why our study was aimed at the utility, assessing the utility and impact of the second duty registrar on patient waiting times. The patient arrival, triage times, and doctor's review times are prospectively routinely recorded in our surgical assessment unit. So we retrospectively, in the first limb of our audit cycle, we retrospectively looked at recorded the data for patient waiting times for the arrival and doctor review times and the triage times in June and July 2018 for a period of 20 days. With the introduction of the second registrar, we recorded the data prospectively for the same months in June and July in 2019 to allow a fair comparison of the two sets of data because surgical assessment unit can be busy or more busy or less busy during certain months. The results were statistically analyzed with the t-test. A total of 182 and 197 patients were included in 1 reg and 2 reg studies respectively. And as you can see in the results section on in the table, that the patients' waiting times to see the senior doctor, which is the registrar, so we would count registrar as the senior doctor, they have reduced statistically significantly in all areas, like arrival to senior doctor review, triage to senior doctor review, and junior doctor review to senior doctor review, and junior doctors was SHOs or the house. Also, there were statistically significantly increased number of discharges in the 2 reg study as well, with a p-value of less than 0.01. So I would conclude that the allocation of a second registrar in the surgical assessment unit decreases patient waiting times for the senior doctor review. It has helped in early decision making and trends towards increased number of discharges, and thereby improving the patient flow. Thank you very much.
Thank you. I don't know if Faz wants to ask a question.
Thank you for your presentation. Do you have a consultant present reviewing patients?
Yes, I mean, the consultants are not present there all the time. However, the consultants do an evening ward round after the consultant on call does an evening ward round around 6, 7 o'clock. And by that time, the patients who are admitted or likely to be admitted, they are there and get seen by the consultants. However, during the daytime, there's no routine for the consultants to come and see the patients. But yes, they do an evening ward round and then the morning post-take ward round.
So have you considered, instead of having a second registrar, to have a consultant? You may find your results are even much better than this.
It's all resource-based, to be honest. Even the registrar availability is all resource-based. We managed to do it for the audit purposes, but we still don't have enough resources to have a regular on-call registrar, second on-call registrar, between in the peak times, and availability of a consultant is even probably going to be more difficult. However, there is a possibility that the on-call registrar maybe could play a more proactive role in seeing the patients in the surgical assessment. Yeah.
Right. Okay, Mohammed, thank you very much. Moving on, last but not least, the last presentation is, what does quality trauma care mean to you? A qualitative study of patients and providers on the meaning of quality care following injury in Zambia, with Ferdinand Mayer. Ferdinand.
Good evening, thank you, and thank you for staying till the end, everybody. So this project was about determining what quality means in this specific context. A lot of research has been done on what quality is, what is medical quality, but they come from high-income countries, Europe and North America. And with King's College setting up a partnership in Ndola Teaching Hospital in Zambia, we wanted to determine some of these other dimensions that may have not been talked about in previous research. So we did this using the grounded theory method and 18 in-depth interviews. And after analysis, discussion, and all these measures that go into the grounded theory, we came up with essentially the following components of what quality is for patients. So going from 1 to 4, 1 being the most important one, 4 being the least important one, are as follows, and that's restoring normality. So returning to life the way it was before the injury is the most important thing of quality for these patients. The second aspect was trusting the provider, having full trust in the provider's ability and capabilities, and that their alignment is the same as the patient's, so that the goal is the same. Thirdly is having some autonomy and respect while in the hospital, so the patients realize they can't do everything they want, but they still want some abilities left. They want to clean themselves, eat the food they want. And fourthly is enjoying life. So that's entertainment and all these little things that you may do while at home, but you can't do in the hospital. So these are the 4 main themes that high quality care means in this setting for patients. For staffs, and I just realized I made a mistake. So the second component should actually say components of quality for staff, not patients. These would be from 1 to 3 again. 1 being the most important is healing and avoidance of patient suffering. So this would be the most important thing for staff. Second would be having opportunities for continuous education and development, and also having a sense of fulfillment and satisfaction. And if you can fulfill all of these categories in this setting, that would say you provide high quality care. And this is quite unique in this case, because most current aspects of high quality care or dimensions focus very much on what patients want, what patients are looking for, so mortality rate and outcomes and things. But this theory suggests that if you want to provide truly high quality care, you also fulfill the dimensions that the providers want for, such as continuous education and having a sense of satisfaction in their daily lives. And that's me then. Any questions?
Thanks. Raz, do you want to ask any questions?
Yeah, thank you very much. So how do you think this translates in the UK?
That's a very good question. I suppose it would be interesting. I'm not sure how useful it would be to do in the UK, because there has been a lot of research done in high income countries. And I'm sure between North America and UK, there would be a lot more similarities than perhaps a high income country and a low middle income country. But it would be interesting nonetheless to conduct something like this on a ward and ask the patients in a structured manner or in a research capacity what they really want. And I'm sure there would be some interesting things that would come out of it that would improve the quality that the department can deliver.
Okay, well, thank you very much. That's excellent. I'd like to thank all the participants in tonight's session. It's been an excellent session. And just to let you know that there are a further 75 e-posters on these topics to go and look at today, asgbi.org.uk/events, if people would like to do that. Obviously, I want to thank everybody who's contributed, and certainly my co-chair of ours. And I'd also really like to thank Barb, Carol and Vicky from the Secretariat for putting on this virtual Congress. I think you've done a brilliant job with this. I've really enjoyed it. And I'm looking forward to the next session, which is next Tuesday night, Tuesday the 18th, and would encourage everybody to sign up for that if they possibly can. So on that note, wish you a good evening, hopefully a nice evening, maybe a little cooler evening later on, and thank you very much.